Hello and welcome yet once again to Conceptual Surgery. I am Dr. Anubhav Vindal, Professor of Surgery at MAMC, and in this lecture of Conceptual Surgery, we will be learning about thoracic trauma. Now, thoracic trauma, as you all know, is a very important subject that all surgeons should be aware of, both from the management point of view and also as an important subject from your examination point of view. As far as the management point of view is concerned, thoracic trauma accounts for up to 25% of all severe injuries. So 1 in 4 injuries of any trauma patients that you see will have some sort of thoracic trauma associated with it. And it is a significant contributor to subsequent death of the patients in another 25%. It is, of all the trauma patients that you see, 1 in 4 trauma patients will have thoracic trauma as a major component, and another 25% will have thoracic trauma as a significant contributor to the death of that patient. Although it may not be the most important aspect of trauma in that patient, but it contributes significantly to the subsequent death of that patient. The most common cause of death after thoracic trauma is hemorrhage. It is easy to understand because all the major vessels and the heart lies within the thoracic cavity. So thoracic trauma is life-threatening either by itself or in conjunction with other system injuries like abdominal injuries or head injuries. The important thing to remember in thoracic trauma is that up to 80% of these patients can be managed non-operatively, and most of them require a simple insertion of intercostal chest tube. What is important is early physiological resuscitation followed by correct diagnosis in order to manage these patients effectively. Now, we all are well aware of the anatomy of the chest wall. So, that's the rib cage, and in between the rib cage are the intercostal muscles. On either side of the midline are the pleural spaces containing the lungs and the tracheobronchial tree. And in the center is the mediastinum, which is flanked on the either side by the mediastinal pleura. The lower limit of the thoracic cavity is formed by the musculoaponeurotic diaphragm, the central part of which forms the base over which the heart lies. So the termination of the great veins and the start of the great artery, that is aorta, all lie within the thoracic cavity. So this shows the vascular system, this shows the respiratory system. You can see the heart, the thoracic aorta, the arch of the aorta, and the descending aorta, they all lie in the thoracic cavity. In fact, the start of all the major neck vessels also lie in the thoracic cavity. So what are the different modes of chest trauma? Most important is blunt trauma. It is very easy to understand. Any blunt force applied either directly or indirectly to the chest wall can cause injury to the structures lying within the thoracic cavity. Penetrating trauma, any projectile that enters the chest causing a small hole or large hole and thereby causing injury to the underlying structures contained within the thoracic cavity is the mode of causing penetrating trauma. Now, this can be projectile which is a free projectile, and it can be a projectile in the form of a projectile which has been introduced, like a stab injury using a knife or any sharp object. And lastly, compression injury, where the chest is caught in between 2 objects and is compressed. Most common example is motor vehicle accident, especially of the driver, where the chest wall is compressed between the steering wheel anteriorly and the seat posteriorly. So there is a compression injury. Now let us see what are the different modes of injury in these patients. So penetrating trauma, it is very easy to understand. Like I said, it could be a free missile in the form of either a gunshot wound, or it could be a missile which has entered by the application of force by hand, like a stab wound. The important thing to know over here is that these types of injuries or trauma concentrates the force over a very small area. So the density or the force which is applied over that small area is intense. All the injury, you can understand, when the bullet is trying to enter the chest wall, it is concentrating all its energy, the velocity and the deceleration energy over that small area with which the bullet comes in contact. Similarly, the point of a knife or a blade also concentrates its force over a very small area, and so therefore the devastation which is caused inside by such a mode of injury is tremendous. Blunt trauma, in contrast, distributes force over a larger area, and the mode by which injury occurs in this mode of trauma is either sudden deceleration or compression or shearing forces, where the organ is attached by is suspended in a cavity by a mesentery, like the lung is suspended by the tracheobronchial tree and by the way of vessels which are arising from the mediastinum by what is known as a pulmonary ligament, which is nothing but a reflection of the mediastinal pleura. Or in case of heart, where the heart is suspended by the great veins and the aorta in the pericardial cavity. So there is sudden deceleration and there is shearing or tearing of the structure, where the mobile and the fixed part, there is an interface between the two. And lastly, bursting mechanism. What are the signs which are indicative of chest injury or thoracic injury in any patient? So when you see a patient of trauma, if the patient is in shock, it is indirectly indicative of loss of a large volume of circulating blood. If the patient is cyanosed, then obviously there is something wrong with the oxygen exchange mechanism of the body, and the oxygen exchange takes place inside the pleural cavity. If there is hemopsis, that means there is bleeding into the tracheobronchial tree. If there is obvious contusion over the chest wall, then it is very easy to suspect that there may be injury deeper inside the thoracic cavity as well. If there is an obvious flail segment, we are going to learn what is a flail segment. If there is an open wound, if you see that the neck veins are distended, so normally the neck veins would be collapsed, but if they are distended, or if there is an obvious tracheal deviation. So these are very, very important signs. You must be very, very aware and very, very, you have to have a very high index of suspicion to pick up these signs in any patient of trauma who presents to you in the clinic. Now, again, coming back to the causes of thoracic injury, it can be blunt trauma, it can be penetrating trauma. So let us look at some examples. So blunt trauma, like I said, motor vehicle accidents. It can be fall from height and it can be blast injuries. Penetrating trauma in the form of gunshot wounds, it could be in the form of stab wounds, and it could be in the form of shrapnel wounds. So whenever a patient of trauma comes to you, the first thing that you do in order to manage this patient is to do the primary survey and to do the secondary survey. So ATLS protocol is the protocol that is to be followed in all trauma patients, immaterial whether it is head trauma, whether it is thoracic trauma, whether it is abdominal trauma, whether it is extremity trauma, or whether there is a multiple system involvement. So what is the primary survey? Easy to understand: A, B, C, D, E. A for airway, B for breathing, C for circulation, D for disability or dextrose or drugs, and E for exposure. So primary is called primary because it takes precedence over secondary survey. Primary survey is to be conducted rapidly because these are the things that are going to kill the patient. Any interference with the airway, any interference with the breathing, that is the respiratory mechanism, any interference with the circulation, that is the heart and the great vessels, any disability, obvious disability, any fall in the blood glucose levels, any drug overdose, and finally exposure, hypothermia, which may cause decrease in the core temperature of the body and ultimately death of the patient. After the primary survey has been conducted and the patient has been labeled as stable, you move on to the secondary survey. Mind you, you do not move on to the secondary survey if the patient is unstable. Secondary survey is a more detailed survey which takes a longer time, and obviously once you have taken care of these 5 things which kill the patient, you have more time in order to assess the patient and to see what is exactly wrong and to correct it. So after A, B, C, D, E comes F, which is for fluids. You take IV access and start IV fluids. You introduce Foley's catheter to monitor urine output. You check whether the patient is having any fever or not in order to rule out sepsis. You introduce a nasogastric tube. So G is for tube. You introduce a nasogastric tube to decompress the stomach. So it will be both therapeutic as well as diagnostic for any bleeding in the upper GI tract. You take a detailed history either from the patient if the patient is conscious and verbose, or from the attendants or any relative of the patient who may be accompanying, or a paramedical person who has extracted the patient from the site of injury or from the site where the patient has sustained trauma to the hospital. And H is also for a detailed head-to-toe examination, which is just like any systemic examination that we conduct for any patient that we see in the clinic. I is for investigation. So investigation is targeted investigations depending on what we have gathered from the history and head-to-toe examination. And J is for judgment, in order to determine what is wrong with the patient, to make a working diagnosis and to decide the further plan of management.